That she didn't mention about she didn't mention about temperature and IV fluids, sir.
And she mentioned
Intraoperative.
goal-directed fluid therapy. I think that word she used. And then
Enough. Okay.
she used
Mm.
warmers, and I think she mentioned that. I heard that.
Okay.
Yeah.
Okay, sir.
So first you define obstructive sleep apnea, which is a periodic, partial or complete. It need not be all the time complete obstruction of the upper airway during sleep. And this causes repetitive arousal and to restore the airway. So all the manifestations like headache, aggressive mood, disturbed behavior, all these things are there, especially in children. And it may be associated with oxygen desaturation and hypercarbia also, later on producing cardiovascular dysfunctions. So first you do history taking. I have, for want of time to discuss it fast, I have not included history taking here. So you always include history taking, and then pre-op evaluation, you have to go through the medical record review, patient family questioning, and physical examination. This is the thing that you have to remember. And then medical record review, what you do is characteristics associated OSA that may be available in the record, such as hypertension, history of myocardial infarction, diabetes mellitus, abnormal cephalometric measurements, or earlier history of stroke, and certain congenital conditions like Down syndrome, especially in children, and neuromuscular diseases may be associated with OSA. And the patient family interview screening protocol, this is mainly for people who have not been identified as a OSA. When they come for a laparotomy first time as an elective patient, their appearance makes you suspect that they may be having OSA. In that situation, if you ask the patient, do you snore, do you get obstructed, he may not remember that. But his wife or family members will be able to say, yes, sir, his snoring is so loud, nobody can sleep in the room where he is sleeping. So this protocol is very important to say about the OSA. Stop bank questionnaire will be useful to confirm OSA. And then coming to physical examination, you go for conducting a directed physical airway examination by neck circumference, tongue size, nasal and oropharyngeal air structure. And then recommendations for preoperative preparation will be either a CPAP should be either initiated, or if it is already been in use, it should be continue to be advised to continue the same thing. And where they don't respond to CPAP, you can advise NIPPV also, non-invasive positive pressure ventilation. And some cases where elective laparotomy, they have time, you can do what is called mandibular advancements or oral appliances, and also advise them for weight loss. For example, a patient with coming for a laparotomy, which is planned 2 months later, then you can do all these preparations. And patient who had a corrective airway like uvuloplasty or surgical mandibular advancement should be assumed to be at the risk of OSA complications unless he says there is a normal sleep pattern in the sleep study which proves that there is no obstruction. And patients with known or suspected OSA may have difficult airways, therefore should be managed according to the practice guidelines of managing difficult airway. Coming to intraoperative management, you have to, the increased choice of anesthesia technique is very important. Airway management is very important, and patient monitoring is the third thing which you have to take great care of. And choice of anesthesia, when you think of sedation, patient previously treated with CPAP or an oral appliance, they are using the modalities during sedation. For superficial procedures, you can use local infiltration anesthesia or peripheral nerve blocks with or without moderate sedation. Though we have talking about laparotomy, these points for skin infiltration, you can use this as a mode of post-op pain relief. And coming to regional, the conduction of anesthesia, spinal or epidural, should be considered in peripheral procedures. Of course, this is not for this particular question as a general rule. and upper extremity surgery can be performed under upper extremity block for all OSA patients. And tumescent local anesthesia may be used for surface procedures like liposuction. So if you have a case of laparotomy with liposuction abdominoplasty, then tumescent local anesthesia definitely has a role. And coming to general anesthesia, use mostly short-acting agents that allow for more rapid restoration of consciousness and return of baseline respiratory function. And wherever airway, you should have a secure airway in all cases where you think of giving deep sedation or mechanical ventilation. So avoid excessive intravenous fluid administration because that will make a rostral fluid shift and worsen the airway edema. So fluid should be given, especially in obese patient, only through ideal body weight, which we have discussed earlier while discussing about obesity. And the full reversal of neurovascular block should be verified before extubation. And patients at increased risk of OSA should be extubated while awake. And extubation and recovery should be carried out either in lateral, semi-upright, or in non-supine positions. And with susceptible respiratory depressant effects, always take care of give minimal sedation, opioids, or inhaled anesthetics. And they should be, if at all, you can avoid all these opioids and sedatives is better. And opioid-free analgesia is the safe option. So mention that word in your answer. And coming to monitoring, continuous monitoring with pulse oximetry is very, very important. And capnography helps in early detection of respiratory depression. Whenever CO2 levels go up, that means patient is hypoventilating. And BP monitoring may be challenging if they are obese OSA. They may require extra large cuff. If not available, you can apply the standard cuff in the forearm. And intra-arterial BP may require in morbidly obese patients who also have OSA. Coming to airway management, patient-associated obesity and OSA may have multiple variations in upper airway. And so when they are associated with OSA, there may be difficulty both in mask ventilation as well as in intubation. So precautions like the ramp position for induction and intubation is very important. Also, you can apply positive airway pressure or non-invasive positive pressure to extend the safe apnea period. That word also you have to include in these cases. So, and rapid sequence induction, even for elective cases, you mentioned about only laparotomy as an emergency. In all obese patients, it is a better practice to go for RSI rather than the conventional mask ventilation and intubation. So increasing the safe apnea period by other methods of HFN, Thrive, all these things should be planned if you anticipate some amount of difficulty from the different from the conventional EC cases. Elective awake fiber optic intubation is a very, very safe method. Nowadays, it can be performed easily under topical anesthesia. So this will be a very useful, but at the same time safe option for all these cases. And you must also have things ready for emergency front of neck airway access. That also should be mentioned. And so these are a few points which you have to add in your answer. This is not a complete total answer for the question that has been asked, but I thought I will just mention a few points which have to be included. So in this you can include ketamine infusion and desflurane inhalation during intraoperative maintenance also you can include. Okay.
Okay, sir.